Corey, thanks again for inviting me. It's always nice to come to New York in November. I appreciate being here. He asked me to talk about new radiation approaches for locally advanced lung cancer. I'm basically going to give a synopsis of a lot of things, or my perspective on some of the trials he mentioned to you, and then I'm going to mention some early phase trials with new radiation approaches. So lessons learned from RTOG dose escalation trial that was called RTOG 0617. I want to touch on proton beam radiation therapy for lung cancer. I'm going to go over current clinical trials that are relevant specifically to radiation dose and technique. I'll touch on the Pacific data in a slightly different angle than Corey did. I included postoperative radiation. There's a current trial in Europe that's addressing postoperative radiation for patients with N2 disease. And then another exciting radiation technology is called hippocampal avoidance with either whole brain or prophylactic cranial radiation. And if I have time, I'll go through that. So we presented these data at ASTRO last September. Corey showed you the schema. This was a randomized trial, 60 gray versus 74 gray with concurrent chemotherapy. I don't know if this projects or I can point to it, but the 5-year follow-up data, the 5-year overall survival in the 60 gray arm is 32%. And that's remarkable. That's a third of the patients out 5 years, which is a new landmark, I think, for non-small cell lung cancer, stage 3. It did better than the high-dose arm at 23%. And Corey, and the median survival was 2.4 years or 28.7 months for the standard dose arm. Corey asked me what the progression-free survival was, and Corey, I looked it up, and it's 12 months for the standard, the 60 gray arm. And these are the curves with overall and progression-free survival. The progression-free survival, was 12 months, Corey. So if you're going to go back and compare to Pacific, which we'll do in a few minutes, the PFS here on the progression-free survival curve for the best arm was 12 months. We did a multivariable analysis for overall survival, asking what factors are important in determining patient outcome, and radiation dose level was important, standard dose being better. Institutional accrual volume. If patients entered at an institution with 4 or more accruals had a 10% survival advantage. Imagine that, a patient who walks in the door of a clinic that submits more than 4 patients on this trial had a 10% survival advantage over those that didn't. I think some of that's use of IMRT, which we'll touch on in a minute. Some of it is supportive care, et cetera. Esophagitis, the patients who got esophagitis had a poor outcome. The volume of the PTV, that's called the planning target volume. So the larger the tumor volume, the worse the patients did. And heart V5. Heart V5 is the volume of heart receiving 5 gray. And that was statistically significant, and we didn't expect that. And if you took V5 out and you said the volume of heart receiving 20 gray, or the volume of heart receiving 40 gray or 50 gray, all of that showed up on multivariate analysis as important. So heart dose is important. Probably the reason why the high dose arm did not do as well is related to heart dose. If you constrict the dose and you don't want to treat the lung, you give more dose APPA and you get a higher heart dose, and that's what happened. We published a paper in JCO in 2016. Stephen Chun at MD Anderson was the first author. It was a secondary analysis, and we were looking at IMRT versus 3-dimensional radiation therapy because roughly half of the patients on the trial got IMRT, intensity modulated radiation therapy, and it was the first trial within our cooperative group that allowed IMRT. So, and we wanted to look at overall and progression-free survival, toxicity, et cetera. If you look at the baseline characteristics, the deck was stacked against IMRT. More patients had stage 3B disease, which is contralateral mediastinal or supraclavicular adenopathy. They had higher planning target volumes, which means higher, more tumor on the IMRT arm. So you would expect more toxicity and worse survival with IMRT, yet it looks like in outcomes, 2-year outcomes being overall survival or progression-free survival, local control, that they were equivalent between 3D and IMRT, in spite of the larger tumor volumes being on the IMRT arm. One of the factors that has been looked at is the volume of lung receiving 5 gray, and IMRT, because dose is given today more or less in 360 degrees around the patient. So the 5 gray dose is larger, but that dose bath didn't turn out to cause increased pneumonitis. In fact, there wasn't a significant difference. It didn't predict pneumonitis. So V5 sort of fell out of a dose constraint. I don't think it's very important. It doesn't appear to be in this trial. Effect of IMRT on heart doses, if you look at the V20, V40, V60 of heart, that's the volume receiving 20, 40, or 60 gray, IMRT reduced that value. If you look at the overall survival on univariate analysis, the V20, V40, and V60 are all significant predictors of overall survival. The best predictor in this trial appeared to be heart V40. So what you might want to reduce your heart dose in choosing a radiation technique to deliver 60 gray of radiation therapy. That's what these data tell us, and we've been using that to fight insurance companies because they still fight us in using intensity modulated radiation therapy, but that paper is a good tool to have to fight that battle. What this trial hasn't told us yet is what specific dose constraint to use on the heart. And we looked back at 400 or so patients at Washington University who had IMRT with chemotherapy and just looked at heart dose metric. If we keep the heart V50, or the volume of heart receiving 50 gray, less than 25%, there's a better survival curve. So that's the dose constraint we're implementing at our institution, heart V50 less than 25%. So that's an important variable for, if you're a radiation oncologist, I think, to implement in your clinic. We did a similar analysis within the 0617 data. We recontoured all the hearts so all the structures were consistent, and then went back and did a multivariate analysis again, looking at what factors were important. Tumor location was important. Tumors that were sitting behind the heart in the hilum, specifically the left hilum or in the subcarinal area, had a poorer outcome. And I'm not aware of much data in lung cancer that show that for patients treated with chemoradiation. Treatment-related esophagitis, also poor outcome, heart V45 in this data set, and tumor volume. So a more fundamental question, how do we reduce heart dose and increase tumor dose? So the new radiation techniques, I think that Corey's asking me to talk about, is how do we achieve less heart dose and still deliver that 60 gray to the tumor? We've got a trial ongoing right now looking at protons versus photons. This is RTOG 1308. It's stratifying patients between 3A, 3B disease, gross tumor volume, and histology, squamous versus non-squamous. Patients get 70 gray on both arms. We have very strict dose volume constraints, like for the heart, like what I was just talking about in this trial, which we learned from prior trials. You're allowed to back down to 60 gray. The patients get concurrent platinum-based doublet chemotherapy and consolidation chemotherapy. We have an amendment that's already at CTEP to add durvalumab to this regimen, thinking that that changed standard of care and that durvalumab should be included in both arms of this trial. And we'll see what they say. This is a dose distribution between IMRT and protons. The protons are on your right. You can see that you can reduce the lung dose with protons, and you can also reduce the heart dose. If you look, well, maybe this example is not the best, but you get less spread out of dose with protons, and this is passively scattered protons, compared to IMRT. Xing Liao and others at MD Anderson looked at heart values with protons versus photons, And there, in every case, and you can see on the graph on the right, in every case, the heart dose was reduced with protons compared to photon-based treatment. So it's one way of reducing heart dose and delivering the dose you want to prescribe to the tumor. So we have its current status. We have about 107 patients on the trial. The initial target accrual was 560 patients. We're changing the endpoint. We're going to make that about 300 patients. And these sites are participating. All of those sites have proton beam availability. So we will get an answer to that question. RTOG 1106 is a trial that used PET treatment mid-treatment to fashion a radiation boost to the residual PET avid disease. So this was a randomized phase 2 trial. Patients got a PET up front, and then the standard arms on the left, they got basically 60 gray with carbo and paclitaxel to 1 volume throughout the treatment. The experimental on the arm at the mid-treatment PET, that's after about 19 fractions. Their last, let's say their last 10 fractions got a boost. And so the radiation dose was escalated to a reduced tumor volume to give the last remaining fractions. And the dose escalated up to about 80 gray. So this data is percolating, it's accumulating. I haven't seen the data yet. I expect it will be released sometime midpoint next year. I hope in time for ASCO. Would be great if it were positive. We'll see. This is an example of on the upper part of the graph, the original PET scan, and on the lower part of the graph, what's residual after about 3 weeks of radiation therapy, so you can reduce your volume and reduce normal tissue doses as a result. And then touch on some early phase trials. And again, these are early phase. They don't change practice. It's just an idea of how to reduce heart dose and increase radiation dose. So this was a trial from Kristen Higgins out of Emory. Patients got 44 gray of standard radiation, in this case IMRT at 2 gray per fraction with chemotherapy. And then she gave an SBRT boost, stereotactic radiation therapy. In a phase 1 trial, she had 5 dose levels. They went from 9 gray times 2, 10 gray times 2, and then she went to 5 fractions, 6, 7, and 8 gray each, and she's completed that, and she published it in the Journal of Thoracic Oncology this past year. And she all the dose levels were fine. She didn't run into much toxicity with that, and so she's planning to pursue a phase 2 trial at level 2, 10 gray times 2. It'll be easier on the patient to give 2 fractions rather than 5, is the rationale. And this is an example of an SBRT boost. The original plan on the left, and SBRT boost 9 gray times 2. And these are her local control, distant metastasis-free survival, and overall survival curves. Exciting data, and we look forward to have phase 2 results soon, hopefully. We ran a trial at Washington University trying to reduce the number of fractions from 30 to 15, and this was with proton beam radiation therapy. So this was phase 1. We fixed the number of fractions at 15, and we had 3 levels, 3.5 gray per fraction, 3.75, and 4 gray per fraction. And the table shows you a comparison of what those might be, but basically we didn't run into much toxicity at 4 gray per fraction times 15 fractions with proton beam radiation. So Cliff and I plan to write a subsequent phase 2 trial trying to shorten the overall treatment, and because if you miss the heart with proton beam radiation and you're not seeing much toxicity, why not reduce the number of fractions, reduce the number of visits? Another trial that we did at Washington University is for MRI-guided radiation therapy, and it's just a taste of what's to come. We have a machine, the first machine installed. We've had it 3 years, where we use a 0.35 Tesla MRI. It has 3 cobalt heads. The company's since come out with a linear accelerator version. and each head is equipped with multiply divergent multi-leaf collimators. And basically, because it's an MRI, you can get an MRI at the same time you're delivering X-ray-based radiation treatment. If you have a CT-based imaging system like cone beam CT on a typical linear accelerator, you can't be imaging with CT X-ray-based imaging and give X-ray-based therapy at the same time. But with an MRI, you can get a live image at the same time you're delivering the radiation therapy. And that live imaging is obtained every day. And it's also, you can adapt on that day. If you see a change in tumor or a change in normal anatomy, you can adapt the radiation therapy that day. And you also get information like this. This is, we were giving 12 gray per fraction for patients who had, let's say, node positive stage 3 disease, and they weren't getting chemotherapy. We do have a few patients at WashU who don't get chemotherapy or don't get systemic therapy because of usually poor performance status. And I've been putting them on this protocol, and you can see the first fraction or the planning fraction in A on the left in blue. That's the tumor target. After 6 fractions, it's in purple. You can see it's reducing in size. And then if you plan the radiation therapy, adapt the radiation therapy, you can reduce heart dose like you can in this case. So that's another means of doing that. And if we did 12, this is the first 12 patients, and you can see how the volume reduces over the course of that 12 fractions. So you can adapt treatment mid-course and perhaps miss more heart with each fraction. You can see that here. This is called a dose volume histogram. If you look at the dashed lines in red, that's the heart, and the dashed line in esophagus, those are if you did not adapt at the 6th fraction versus if you did, you reduce dose to those 2 critical structures. So hopefully reduced side effects for the patients. Well, immunotherapy's changed everything. It really has in the past year, and since the results of Pacific came out, it's really changed everything, and we're really having to revise all of our trials within energy oncology to add immunotherapy. And so I want to touch on that a bit. This is Keynote 24, and I'm sure you're going to hear much about it tomorrow. And this is the progression-free survival curve from that trial. In patients with stage 4 disease who were selected with high PD-L1 status. And that's just a remarkable curve. So why not try that in stage 3 in the setting where patients are getting chemoradiation? And so Pacific did that and showed the same curves that Corey showed before. The median progression-free survival was approaching 17 months. And if you look at the best arm of 0617, ours was 12 months. So there's something to that. Now, the control arm was not very good, 5.6 months. But I'm reminded that the randomization occurred after patients got chemoradiation. So the PFS curve started at the time of randomization. So you can, if you want to compare trials, you have to add 2 to 3 months to that value in order to try to compare apples to apples. And so maybe it's not quite as bad as it appears on this curve, but yet it does seem to have underperformed somewhat. About the same time, this trial idea launched in 2011 and was accruing, but with the results of Pacific, we've decided, with BMS, have decided to close 3505. So this trial was open. If it was open at your institution, I guess I'm announcing we're closing it. I don't know if the official announcement has been sent out by RTOG yet. And then Corey mentioned 1306 for patients with EGFR mutations or ALK translocations. This was a randomized phase 2 trial where patients got induction or erlotinib or crizotinib followed by chemoradiation versus straight chemoradiation. And there just aren't enough of these patients in the locally advanced setting to accrue. At least we haven't been able to accrue, and we recently sent a letter to CTEP saying we plan to close this trial because there simply aren't enough patients to complete the trial. Just touch on postoperative radiation therapy. Cecilie Pachou has a trial called LungArt, that is accruing. She told me at World Lung that she thinks it will be open about another year. This is for patients with N2 mediastinal nodes resected, where they get postoperative radiation therapy or not. The reason this is important, and we all go back to tumor boards with the Port meta-analysis showing radiation was harmful for patients with stage 1 and 2 disease, which other data supports that, certainly, but it was unknown whether it helped patients with resected N2 disease or not. So they either get a choice of chemotherapy. I suspect most of them are getting chemotherapy, followed by nothing, or followed by 54 gray of postoperative radiation therapy. The primary endpoint is disease-free survival, with some secondary endpoints of local control and overall survival. Finally, hippocampal avoidance. So for patients, this isn't thoracic radiation, but for patients who are getting either prophylactic cranial radiation for small cell lung cancer or have brain metastasis, the RTOG has 2 active trials that are using a technique called hippocampal avoidance. So it's IMRT. You get a special MRI that outlines the hippocampus, and you can design radiation to minimize dose to the hippocampus to 6 gray or less. So both of these trials are, the PCI trials, 2,500 centigrade and 10 fractions, and you can limit the amount of radiation to 6 gray or less to both hippocampi. And so we have a trial called CC01 for patients with brain mets. They get memantine in whole brain with or without hippocampal avoidance. The dose is 30 gray and 10 fraction for both arms, and this trial is accruing gangbusters. Better than anticipated. I don't think it's going to be open another year. It's already over halfway through its accrual, and I think this slide's about 6 months old. Likewise for PCI, the same idea. Patients get hippocampal avoidance versus nothing in the setting of PCI, and likewise the accrual of this trial has been going really well, and it won't take long to read out a result from either of these 2 studies. So in conclusion, current efforts are towards treating smaller radiation volumes, limiting heart dose, and or adapting volumes during the course of radiation therapy. The trials include protons versus photons, use of a mid-treatment PET to adapt, newer strategies using an SBRT boost, proton hypofractionation, et cetera. And the answer to my question is here. Maintenance immunotherapy, DERVA, has drastically changed, to me, the standard of care, although it's not FDA approved yet. The NCC guidelines have already changed in that direction. Several amendments are underway in our trials to include these agents, and the next criticism of that trial is there was no radiation therapy QA. So maybe that's the result of why the control arm didn't do very well, yet the treatment arm did better than one would expect. And we anxiously await the overall survival results. Thank you.